A very good morning to all. I bring greetings from NIMHANS, Bangalore. At the outset, let me thank the organizers of ISNAC 2022 for inviting me to speak on airway management in neurosurgical patients. This is the learning objective of this presentation, to know about the airway concerns in neurosurgical patients, how to assess the airway, challenges that are likely to be seen in the airway management and maintenance, and approach to airway management in specific neurosurgical conditions, and lastly, end with extubation concerns and measures to overcome them. So the airway management in neurosurgical patients impacts the intracranial homeostasis and neurological outcome. And over a period of time, the expansion of neurosurgeries has enhanced the airway challenges for the anesthesiologist. The airway concerns are more in emergency neurosurgery as compared to elective neurosurgery. But in elective neurosurgery, the management has to be individualized based on the pathology such as acromegaly or cervical spine disease, and surgery such as spine surgery, etc., where the posterior fossa surgery, where the concerns are slightly to be different. Overall, airway management in neurosurgical patients require careful planning, optimal preparation, and deft performance for successful outcome. So the airway in neurosurgical patients is slightly different for management as compared to non-neurosurgical patients. And we all know that any airway misadventure in these patients can lead to hypertension, hypotension, hypoxia, and hypercarbia, which can affect the intracranial dynamics, such as aggravation of the raised intracranial pressure and compromise in the cerebral oxygenation and perfusion. And therefore, it is important to ablate cardiovascular and intracranial response during airway management using titration of the anesthetic drugs and dosage. And lastly, a smooth and swift airway management both at intubation and extubation is vital to minimize the impact on intracranial dynamics. Now, what are the airway concerns in elective neurosurgery? This is broadly, I have mentioned what are commonly encountered problems. One is the cervical spine pathology such as atlantoaxial dislocation, ankylosing spondylosis, rheumatoid arthritis. All these patients require good assessment and preparation to prevent any airway problems. Remember that patients who have undergone temporal or frontotemporal craniotomies earlier can manifest with pseudoankylosis of the temporomandibular joint. Similarly, patients who have undergone transnasal transmural surgery or have CSF rhinorrhea can be a challenge for mask ventilation, which can lead to pneumocephalus or infection, and therefore modified rapid sequence induction in these patients is desirable. In children, the complex airway challenges can be complex because of the large head, presence of encephalocele, and syndromes associated with the pediatric neurosurgical conditions. Any abnormal position during surgery can result in challenge in maintaining the airway in a secure position, and also there may be a need to rescue the airway when there is a airway complication. And lastly, a good extubation plan is necessary, and the management after extubation has to be understood by all the stakeholders for good outcomes. Now, this slide summarizes the airway concerns in emergency neurosurgical patients, especially those with traumatic brain injury. You have a patient with the raised intracranial pressure, and it can get aggravated during airway management. A patient who is comatose, not responding, airway assessment is not possible. The airway is not certain. We don't know whether there is blood, secretions, food particles in the airway, and that is only seen when we do a laryngoscopy. There can be extracranial injuries associated, such as cervical spine injury and maxillofacial injuries, which can create problems during mask ventilation and intubation. And the physiological difficult airway is when there is desaturation, hypotension, and this can lead to intracranial dynamic changes, which are detrimental to a good outcome. Coming to the airway assessment in neurosurgical patient, a good thorough evaluation is necessary irrespective of the anesthetic technique that you're going to adopt. We need to identify patients with difficult mask ventilation and intubation. Remember that complete airway assessment may not be possible in patients because they are subnormal, they have subnormal consciousness. It could be pediatric neurosurgical patient Supine position because of traction, airway assessment in supine position may have to be performed, and the complete range of cervical spine movement cannot be assessed. And in these situations, radiological assessment may add on to the information regarding difficult airway. The clinical assessment generally involves this lemon criteria for identifying difficult airway. You look for facial trauma, incisors, small stage, large tongue. Then the 3-3-2 rule, 3 fingers for interincisor gap, 3 finger between the hyoid and the mentum, and 2 finger between the thyroid and the base of the mouth. And Mallampatti assessment from class 1 to class 2. And O is self-explanatory, obstruction because of epiglottitis, abscess, edema, trauma, etc., and neck mobility. In patients with pituitary lesions, acromegaly, also there can be some additional challenges. A large tongue may be present, a large teeth may be present, the oral intensor distance may be narrow. There could be a decrease in the temporomandibular, the thyromental distance. Neck circumference may be large. The limited mobility of the cervical spine, especially with regards to extension. The upper lip bite test also provides some idea about a difficult airway in neurosurgical patients. And in supine patients, we need to perform the Mallampatti grade assessment in supine position. Cervical movement assessment is difficult, and but Mallampatti grade has been tested in supine positions as well and shown to predict a difficult airway in if not better than the upright position. Because of the COVID times, virtual assessment of the airway has been attempted, and this particular study from Srichitra has shown that it is feasible to perform virtual airway assessment. And when these clinical assessments are not possible, or to add more information to the clinical assessment, radiological assessment are performed. This is the flexion extension X-ray of the cervical spine, and this is the chest X-ray, which gives us more information regarding the likely challenges in airway management. Here you can see that there is, because of the pulmonary fibrosis, there is a deviation of the trachea, and here you can see a large bullae which can positive pressure ventilation can result in rupture and then result in airway complications, respiratory complications. So we need to be mindful of this and utilize the lung X-ray, chest X-ray also to plan your airway management. CT MRI are generally performed for primary pathology, be it brain lesion or a spine lesion. And they also provide us information on the airway problems, the tracheal dimension, the epiglottis size, the size of the tongue, the space, the uvula, and that will help us in planning our airway management better. And lastly, bedside ultrasonography is now commonly used for assessment of airway in neurosurgical patients as well. The specific neurosurgical population present with unique challenges, and these need to be understood, especially in pediatric neurosurgery, traumatic brain injury, spine surgery, aneurysm surgery, pituitary surgery, stereotactic surgery, awake craniotomies, and posterior fossa surgeries. We look at them one by one. Hydrocephalus can result in challenge both physiological difficult airway and anatomical difficult airway because of the malalignment of the laryngopharyngeal axis, and physiological because of the further increase in ICP during airway management. Patients with occipital and frontal encephalocele can present difficulty in mask ventilation and in intubation. This patient may require intubating in the lateral position. Patients with craniosynostosis can have some facial dysmorphism because of the syndromes associated with that, which can make airway management difficult. Now, especially with patients having encephalopathy in children, both mask ventilation and intubation can be difficult because of the associated problems such as hydrocephalus, clipperfield, and subglottic stenosis and micrognathia. And as I mentioned, intubation, lateral position, platform, rolled blanket, dural laryngoscope use may be required. And also the care during the procedure per se, and also at the end of the surgery during extubation needs to be taken. There is no best or safe technique for airway management in traumatic brain injury. It depends on the urgency of the situation, the expertise or skill that the operator has, and the resources that are available at that particular point of time. The usual practice is to perform oral intubation using manual inline stabilization with rapid sequence induction and precord pressure. Both succinctune and brocuronium have been used in these scenarios. When the patient is already intubated, it's always advisable to reconfirm the airway and oxygenation and ventilation, because especially when it's performed as a casualty by a non-anesthesiologist. Secondary insults should be avoided during airway management, especially hypotension, hypercarbia, hypoxia. Newer gadgets such as video laryngoscope, ventilating bougie can facilitate faster intubation without any secondary insults. The spine pathologies, especially chronic spine pathology, can be associated with poor pulmonary reserve, myelopathy, and elderly. These patients are elderly. So video laryngoscope may be a better choice in this particular patient. Whereas in acute cervical spine injury, there is further risk of neurological worsening, autonomic instability, and airway management may be emergent or urgent. In these situations, awake fiber optic intubation or awake intubation with laryngoscope, video laryngoscope may be preferred, and this will help us in assessing post-intubation neurological status as well. But there are certain challenges. Airway assessment becomes limited in cervical spine patients. The airway can be difficult because of the spine immobilization from hard collar traction or manual stabilization. And lastly, we need to prevent cervical spine movement during airway management, which results in
there's an interruption in the feed. The connection is lost with Dr. Sriganesh.
Organizers has to continue. Actually, Sriganesh is available here, but this slide sharing has been stopped.
In these situations, alternative intubation techniques should be explored. And in this particular study, we compared video laryngoscope with fiber optic scope and found that the degree of cervical spine injury is not significantly different, and no patient developed new neurological deficits after intubation. And this was again also seen in where when we compared fiber optic intubation with intubating laryngeal mask airway assisted with neurocritical intubation. Again, this was found to be equivalent. So video laryngoscope or intubation through a intubating laryngoscope is feasible without any additional risk of neurological injury in patients with unstable cervical spine where fiber optic intubation is not possible for any reason. In this study, we evaluated the opinions of anesthesiologists about, for performing intubation for neurosurgical procedures, and the reasons for choosing a particular intubation technique was the familiarity and availability, and less likely to produce neurological changes. These were the three most common reasons for choosing one particular intubation technique. And when the respondents were asked which airway maneuver is likely to result in maximum cervical spine movement, majority of them mentioned that it was chin lift, jaw thrust, and head tilt. And the least maneuver that is likely to cause cervical spine was awake fiber optic intubation. The next, moving on to aneurysm surgery, there is one report which mentioned about rebleeding during airway management, and therefore care has to be taken while securing the airway in aneurysm patient. There could be large glottis, hypertrophy of soft tissues, and limitation of mobility. None of the conventional airway assessment tools predict difficult intubation, and these patients are likely to develop post-extubation laryngeal bronchospasm because of the clogging of the airway after surgery, airway obstruction, desaturation, resulting in reintubation. Remember that the nose is packed in this patient, and after extubation, if there is a need for reintubation, remember that patients can have CSF granules, can lead to pneumocapillus after during because of the mask combination. The next surgery is stereotactic surgery. The mask ventilation can be difficult, as you see on the left side of the screen, but intubation is generally not difficult because of the newer stereotactic frames. However, a balance between sedation comfort and likely respiratory problem because of sedation and need for emergent airway has to be kept in mind. Awake craniotomy can lead to problems requiring airway intervention. The asleep awake asleep technique can be challenging, especially airway removal and reinsertion. Most often airway intervention is performed to protect secretions or manage seizure, uncooperative patient, and procedural complications. To rescue airway compromise from oversedation or ictal apnea, to reduce brain swelling from hypoventilation and desaturation. But there are certain obstacles for emergent airway management during awake craniotomy. The presence of the Mayfield head clamp restricts the head and neck movement. Need for maintaining sterile operative field, non-availability of space at the head end, fixed or extended fixed head position, and acute changes in neurological cardiorespiratory status is likely, which warrants a quick airway management in patients requiring emergency airway management during awake craniotomy. The most commonly used gadgets are supraglottic airway devices and video laryngoscopes. This is an example of apnea during awake craniotomy, and how high flow nasal oxygen can prevent desaturation and airway obstruction, need for reintubation and management during seizures. Posterior surgeries per se may not present difficulty in securing the airway, but there are certain issues that we need to take into account during airway management. Remember that airway reflexes are poor, so judicious extubation decision has to be made. Most of the time, posterior surgeries are performed in non-supine position. The choice of tube becomes important. Mostly we use the flexometallic tube. And when certain conditions warrant awake intubation and awake positioning, this has to be considered using comfortable drugs such as dexmedetomidine. And there can be multiple neurofibromas in the airway in patients with CP angle lesions. This also needs to be aware and plan for management, especially when you look at the images. The last part is, next part is regarding airway complication during neurosurgery. This table lists the potential complications in the perioperative period: postoperative airway obstruction, accidental disconnection, accidental extubation, kinking of the tube both internally and externally, bite injuries, dental injuries. The likely cause, the manifestation, and possible solutions are informed here. The choice of airway and complications, LMA has been used in neurosurgery, but it may not be suitable for all types of surgery, especially V-patient surgery, where we observed the loss of ventilation because of the extreme neck rotation and tunneling in these patients. So judicious selection of airway is important. Similarly, if the patient is likely to be sent to ICU on tube, then it's better that we select subglottic suctioning tube so that the incidence of ventilator pneumonia can be reduced. Now, during intubation, so there can be a dental injury, and however, it has to be identified and rectified immediately. Similarly, temporomandibular joint dislocation can occur during intubation, and again, this needs to be identified promptly to prevent long-term side effects. The other common complication during prong neurosurgery is tube kinking, especially with fish hook retractors, abnormal neck positioning, and especially when intraoperative neuromonitoring is used, motor airway potential especially, and no muscle relaxants are used. Also, the use of transdiaphragmatic echocardiography can result in airway obstruction, especially at the tip where it is very soft in flexometallic tubes. Then there can be position-related complications, especially in sitting position, prone position, and lateral
मैंने
position.
देखा नहीं है पेशेंट
Rotation
कोई कोमोबिलिटी से
and kinking of the
इको हुआ है उसका
tubes, right tube,
अच्छा
which can
अच्छा
induce
नहीं मतलब डिलीरियम कितना है उसका
and then lead to postoperative complications. Hemodynamic complications are commonly seen despite adequate depth of anesthesia and good doses of analgesia, and these can have adverse impact on patients with raised intracranial pressure or intracranial aneurysm. Last part is regarding the extubation concerns. Again, it has to be swift and smooth like intubation, and hemodynamic activation can result in brain edema, hemorrhage, delayed awakening, additional investigations, redo surgeries, and poor neurological outcomes. Therefore, ablation of this response has to be taken care of by using lignocard, additional opioids, continuing dexmedetomidine sedation, and deep extubation. But remember that neurosurgical patients, especially those undergoing posterior fossa surgeries, have a higher incidence of pneumonia and reintubation. And if reintubation is required, airway can be difficult because of macroglacia, orofacial swelling, airway edema, obstruction, pseudoankylosis, lower cranial or recurrent laryngeal palsy, cervical fusion, and brainstem dysfunction. Now, certain intubation characteristics can inform the likelihood of difficult extubation, such as number of attempts, number of persons involved in intubation, number of alternative technique used, Cormack Lana grade, lifting or force or laryngeal pressure, and vocal cord mobility. This is known as the intubation difficulty score. This will help us in identifying patients who are likely to have a difficult or problems with extubation. Now, the awake versus deep extubation has been debated. There are certain advantages, disadvantages of either technique. Awake extubation can provide immediate neurological assessment, whereas it can result in hemodynamic activation, and consequently intracranial dynamics changes can occur. Deep extubation provides smooth, pain-free awakening without any significant systemic or intracranial dynamic fluctuations. However, the disadvantage is inability to assess neurological status and potential for aspiration and airway obstruction. Reintubation after neurosurgery is a challenge. The common causes are neurological deterioration, respiratory distress, unmanageable secretion, and seizures. This can be prevented to some extent by careful patient selection for on-table extubation, adequate and complete neuromuscular blockade reversal, ensuring return of consciousness and recovery of swallowing and airway reflexes. Despite that, there can be possibility of reintubation, and this has been documented in patients with cerebral pathology. Lastly, I'll take you through quickly through the flow charts for airway management in elective craniotomies. Remember that we need to avoid hypo or hypercarbia, hypoxemia, hemodynamic appeals in patients to prevent further aggravation in raised ICP, and also to prevent rebleeding aneurysm surgeries. If the craniotomy in patients with difficult airway, awake fiber optic should be considered, and if mask ventilation is easy, video laryngoscope or asleep fiber optic intubation should be performed. If the awake craniotomy is planned, then keep supraglottic airway devices ready and be prepared for emergent airway. Intubation strategies for cervical spine depends on the awake intubation or asleep intubation. For awake intubation, good preparation is important. Remember that airway assessment is possible in this, whereas in asleep, it is neurological assessment is not possible. Common immunization techniques have their own disadvantages, and the intubation technique which produces the least cervical spine movement should be selected. Lastly, extubation strategies for elective craniotomies avoid common problems that occur: hyperoxia, hypercarbia, hypoxia, hemodynamic appeals. Extubate when extubation criteria is fulfilled, that is, patient is conscious, gag and cough reflexes are present, breathing is regular, good tidal volume and rate, and neuromuscular blockade is completely reversed. In difficult airway, be prepared for complications, keep tube exchanger ready, and if all these attempts fail, then tracheostomy can be performed. To summarize, difficulty in securing the airway remains a major cause of anesthesia-related morbidity in neurosurgery. Airway management, including extubation, can be challenging, and one has to be prepared. And the key for successful intubation and extubation and overall airway management in neurosurgical patients is adequate knowledge about airway anatomy, anticipating problems, a good assessment of the airway, prepare for a difficult airway, obtain essential skills for securing the airway, and have adequate resources that are essential for safe airway management in neurosurgical patients. Thank you very much for your patience hearing.